No hope. Okay.
No. Regarding corneal blindness, I think corneal blindness is a major problem. We meet many cases in our clinics, either due to corneal degeneration, corneal dystrophy, post-traumatic, or due to ectatic corneal disorders like in keratoconus. And now, I think keratoplasty carries a magic solution for many of these cases, either penetrating or lamellar keratoplasty, and if patients can afford in resistant cases, we may go to keratoplasty. But some of the cases are carrying high risk for keratoplasty, and unfortunately, these cases are mostly poor patients, older aged patients carrying high risk, aiming seeking medical advice very late, carrying also a high risk, or a young child. Like cases of chemical burn or severe chemical burn with severe limbal stem cell deficiency. الحقيقه the limbal stem cell layer is a layer we depend on it for the viability of the graft. هي اللاير اللي انا بعتمد عليها علشان الجرافت يعيش. تخيل بقى انا داخله اعمل كيس I have this no limbal stem cell. Or cases with age or young age like a child. And in a child you usually postpone the keratoplasty surgery as much as we can. واحنا دايما نزقه لبعيد ونحاول نبعده عن الكيراتوبلاستي على قد ما نقدر. But sometimes we have the risk of amblyopia, and unfortunately in some cases we have emergency cases like perforation or pathological perforation in this age. So I have to interfere. What I can do. And also in active corneal infections or severely dysorganized eyes, carrying also the high risk of rejection. الحقيقة in these cases, sometimes good preparation is the key for solving these cases. In severe chemical or corneal burn, the first challenge is having a severe limbal stem cell deficiency في الكيسز دي. واللي بقى subsequently على طول بيعمل conjunctivalization ويبقى very recurrent even with trial to remove. يشيل وبرضه على طول ترجع الصورة is the same. السكند تشالنج الحقيقه انه unfortunately most of the victims are young age، وده كده انا عندي اثنين ريسك، limbal stem cell deficiency and also young age. So very high risk of rejection. What to do? The solution in these cases, actually the best solution is to convince the patient to do stem cell transplantation. بس الفكره المشكله ان انا عشان استخدم or the problem main problem allogenic stem cell transplantation كان high risk. Even in my experience it wasn't good enough. But you have to talk with your patient. You're always having a patient with non-seeing eye and the other eye is the precious sound eye for him. If you talk with him he will say for you no, stop, I will live with this eye. اغلب البيشنتس لا انا لا هتعملي لي اعملي لي حاجه في العين دي بس العين الثانيه ما تجيش جنبها. So you have to talk with your patient. This patient is a young aged patient, 22 years old, coming with this aggressive conjunctivalization after severe corneal burn. I try to convince him many, even consent on before going to the operative theater, but the patient refused. So what I do, I leave him for amblyopia and this aggressive conjunctivalization which increases with time, or I proceed. I try to proceed. I try to search for another way, the limbal stem cell transplantation, and this was the surgery. Trying to dissect. The key to reach the good division plane between the cornea and these adhesions. You can reach this plane, and then try to dissection, which is the aggressive conjunctivalization. They try as much as possible. Always I say to this patient, it's just a step before keratoplasty. We are doing a step before keratoplasty. Even if your target to prepare an eye suitable for keratoplasty, this is only success. And then amniotic membrane transplantation, trying to stabilize the corneal surface and trying to do revitalization. And then when the patient refuses, I try to go to other growth factors like I used, actually in this case, hereditary plasma, autologous for the same patient, and also I depend on umbilical cord derived hereditary plasma. And then this is the case, 2 weeks post-operative, and then we reached some satisfactory, not like autologous stem cell transplantation, but for me, reaching just an eye suitable for Keratoplasty, I think the patient before is never suitable for any keratoplasty. In another case, this mother having a child, she came for me when she is 3 years old with this also aggressive chemical burn with conjunctivalization, and she refused too much for doing stem cell transplantation. But she came now after 3 years, and she, because he has a mild ptosis, she said before she told me, okay, take from his other arm. الأول قالت لي لا جنب عيني الثانية، وأنا I cannot convince her more، يعني الحقيقة أنا زيها أنا ما أقدرش. فقلت لها تمام، هي she insisted this year to do because her child is having a mitosis, and the oculoplastic surgeon told her that please start first with autologous stem cell transplantation. Then we started, and also in child reaching the cleavage plane is not so easy like in older age group. But we tried also. But now I have to take from the other eye. I think in this age, taking growth factors is not enough. So, 2 clock hours, autologous limbal stem cell from the upper quadrant and from the lower quadrant. Like it wasn't easy for the mother, it wasn't easy for me. I think Dr. Taha here attended and know that while I'm going to the other eye, it wasn't so easy. ما كنتش عايزة أصلا أجيب بس it was always a push. Because we had to carry the risk of amblyopia in a 6 years child. When I leave him to be suitable for keratoplasty, it carry high risk of another case also. This case, I think 3.5 years ago, aggressive, and then we tried to reach the cleavage plane. But here I remember this patient, he and his mother were convinced from the start because of the disfiguring shape of the arm. Tell the patient we are away from the visual axis in the other eye. Sit in 2 clock hours up and down.
الستم سيل حضرتك الليفل ازاي؟
In 2 clock hours, dissection 2 millimeter, and then go in the thick the conch and piece conjunctival like a carrier for the stem cell, and then go lamellar in the cornea just for 2 millimeters. This is the place of the stem cells. Then this is the case pre-operative, and this is the case 1 week with the stem cell up and down, and then the case 2 months post-operative. This patient came by chance this week after 3.5 years. Then I took the photo with the presentation because I told the patient before this is a step before keratoplasty, but actually the result make me don't need keratoplasty now. The second case. Another case is for carry risk is a young aged patient. This case, I think our great residents know her well, Khadija. She's coming presented with a lower pathological corneal perforation, actually sudden. The patient, I referred her for all immunological investigation, nothing at all. She was free at all. But while I'm preparing her to examine in the operative theater, I discovered something. She was sleeping on her mother's hand, and then I discovered she's not closing her eye well. Although I make always for my patients a lid closure test and build, and I examine personal, but I found here weak lid closure. Maybe this is the cause, and maybe a foreign body trauma, I don't know, but this is the case. What to do? I'm having a young aged male like that, keratoplastic more risk, even tectonic, I always do in many cases, but in this case I was back. This is my examination for the child, Khadija. Then I told that I have a step, I have to prepare, I have to deceive the immune system. لازم اضحك عليه الاول، ما ادخلش على immune system في child just 4 or 5 years old بتكتونيك keratoplasty. So I went first to multi-layer amniotic membrane. Then this is the Khadija opening her eye. Then when I saw her opening her eye, so now I'm quiet. I can go and proceed for tectonic graft. So I went for tectonic graft and I tell the mother again, it's a step. دي مرحلة احنا داخلين على keratoplasty. But fortunately the patient after 3 months, this is a good, I think, good knowing Khadija. And now I think with this vision, just anterior cortical cataract, small, eccentric, fortunately, so I think we can postpone or we cannot go for keratoplasty. Regarding severe disorganized patient or post-infection, in this talk I will not, I think the previous talk I have tectonic observatory cases for infection, but regarding severe disorganized eyes, this a patient, I think he was 19 years old around, coming with a vision, he was hardly BL, and coming for evisceration. But by the way, when I make ultrasonography, the retina is in place, and how can I sacrifice or ازاي اضحي بعين زي دي في الايج ده؟ فكان الديسيجن I have to go. Then I tried to dissect. Patient cannot afford keratoplasty, so we have بعد إذن الوليد bottom graft from a patient prepared for keratoplasty. I tried to make lung dissection, but unfortunately I couldn't. All the tissues were adherent, fibrotic. كل التيشوز كانت حته واحده لدرجه ان انا I was upset and at one minute I stopped.
كلمي عربي براحتك، الدكتور قال لي مش معانا يعني.
ايه؟
كلمي عربي براحتك، الدكتور قال لي مش معانا.
والله انا افتكرته معايا ما يعني خلاص كنت خلاص هحط بس كده جراف مجرد اناتوميكال ريبوزيشن، وبعدين فجاه مع قلت لا طب ما انا اتراي. الحقيقه كانت دي الريزلت. واما الستيب دي دكتور احمد شكري الحقيقه قال طب ما نعمل كمان فيتريكتومي يا دكتور رانيا، وده وصلنا للمرحله دي. فالحقيقه سمعت كلامهم، شكرا جدا، وعملت الفيتريكتومي الانتير فيتريكتومي وكانت دي الريزلت فاينل. الحقيقه البيشنت this picture I think 2 weeks or 3 weeks post operative he's seeing now 260 and he is aphakic. Even if a step it is so finally our whole message preparation and step surgery may be the key for high risk keratoplasty cases, and in many cases with multiple limbal stem cell deficiency amniotic membrane alone may not be enough. Finally, restoring ocular surface integrity is a hard battle, but it deserves with patience. Thank you so much. And finally, I have to thank our brave team